And always fun from the laptop. 1 second. And I'm back on this screen. Okay, got it. We are being live streamed. Good morning, everybody. It is June 3rd, 2022. It is 11:06 a.m. on the East Coast. And I am welcoming you to Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. And I am live right outside of Boston in Burlington, Massachusetts at the brand new HCM program, HCM Center of Excellence at Lahey Hospital and Medical Center. And I am joined by, and I'm going to go down the line here. We're sitting in a row. So if we're looking in the other direction for those who are watching live on Facebook, we apologize if we're not looking at you. So we're going to start with Marty and go right on down the line. Can you give introductions to yourself and let us know who everybody is?
First of all, thank you, Lisa, and welcome to Burlington and Lahey Clinic, where we, as you said, have just launched our new HCM Center and program. I'm Marty Marin, co-director of the Hypertrophic Cardiomyopathy Center at Lahey, and joined by Ethan Rowan and Prem today. Look forward to having the opportunity to chat with you on the podcast today.
Fantastic. Ethan.
Hi, Ethan Rowan. I'm the co-director of the HCM Center at Lahey. Again, thanks, Lisa, for coming out here and letting me join the podcast.
Great to have you. Prem.
Yeah, morning, everybody. And Lisa, thank you very much for the opportunity and for coming over and having me on this podcast along with Marty and Ethan. And we're glad that Lahey Hospital Medical Center is now a center of excellence for HCM. I look forward to it. And as a introduction, I'm the Division Chief of Cardiothoracic Surgery at Lahey Hospital Medical Center.
So this is the first time we have done a live podcast from a center or a site visit, as we call it here at the HCMA. So some of this cast of characters is known to a lot of the HCM community. And some faces might be a little bit newer. I'm going to start with the new guy over here. So Prem, why don't you tell everybody a little bit about your training and how you became a cardiac surgeon?
Sure. My training goes back at least 3 decades now. So I was originally trained as a cardiothoracic surgeon in India and finished my training in 1996. And subsequent to that, I left India after a couple of years to go to Australia. And I was in Australia for 4 years, from 98 to 2001. I did an advanced fellowship in cardiothoracic surgery there. Then I came to Boston, Massachusetts, did an advanced training in adult cardiac surgery at the Brigham and Women's Hospital. And subsequent to that, I stayed at Brigham and Women's Hospital for the next 16 years as faculty. And the final 5 of that was as the Brigham and Women's Hospital Division Chief. And since July of 21, I've been at Lahey Hospital Medical Center as the Division Chief.
So when did you start becoming interested in hypertrophic cardiomyopathy?
I would say about 15 years ago, maybe somewhere in the later part of 2000, say 2007, 2008. That's when I first started doing the myectomy procedures. I can tell you an anecdote if you like.
Please.
Okay.
That's a podcast where we can just chat.
All right. So about 15 years ago, I was approached by a nurse in the surgical intensive care unit who had her children go to school with the children of another gentleman who had HCM, but was a grave digger by occupation. So you can imagine how physically intense that job was. And he was being managed by a local cardiology in the suburban community and was on maximum medical therapy and was told that nothing more can be done. And why don't you apply for disability and move on from there? And this guy was about 35 years old. He had 2 kids, about 8 and 6. And this patient was presented to me. And I said, well, we could do an operation called a septal myectomy. And I had some training in septal myectomy in my lead up to being a faculty surgeon. we did a septal myectomy on this guy, the first one I did at the Brigham, and he went from class 4 symptoms to class 1 symptoms like within 3 months. And it was a dramatic difference in his quality of life. He went back to work. He's still working 15 years later, and he has not needed any other intervention. So I was so impressed by the dramatic change in people's lives that a myectomy procedure can do. And in this particular patient's case, I not only made a difference to him, but his entire family, because he still is constructively employed, not on disability.
Correct.
And that sort of was a segue into what has become an experience of treating patients with HCM and making their lives better. It's been an interesting journey.
So you've moved over here, and then these guys over here, Marty and Ethan's program, came to Lahey officially a month ago, but you guys started working together before the official move. And my understanding is, as of today, there have been 28 myectomies done with the team in front of you today here at Lahey. And I understand all the outcomes have been excellent. And you have not one former patient who's happy post-myectomy, but just in the past couple of months, you've got 28 others. So Marty, what has it been like to work with Prem these past couple of months doing myectomies?
Well, I mean, we couldn't be more thrilled to have the opportunity really to work with Prem and to, in fact, let me say that one of the main reasons actually that the HCM program moved to Lahey was to have this opportunity to, in fact, work with Prem. And as by way of anecdote too, I have been working in Boston now for 20 some years. I've known Prem or his reputation for a long time. And I know that at one point about 7 or 8 years ago, when we were recruiting him potentially at that time to be leader over at my former institution as chair of cardiac surgery, I was a big proponent of trying to get him to come and work with me at that time, because he had such an incredible reputation as a cardiac surgeon, but also an incredible reputation in the myectomies already at that point. So I had really been very excited going back now almost 10 years in terms of wanting to have the opportunity to work closely with Prem and operate on patients with this disease to provide those patients incredible surgical outcomes because of what exactly Prem just said. He couldn't have said it better with that anecdote. Myectomy in great surgical hands provides the opportunity to give patients back their life. And we know better almost than anyone, having taken care of patients now with HCM for 20 years, just how impactful great operation myectomy can be for patients. And that means that we need to be working very closely with a surgeon who can do that. And there's just no question that we have been more than thrilled with that chance with Prem.
So I've had the opportunity over the past day and a half or so to start to meet some more of the faculty and the leadership here at Lahey. And you've got some amazing new team members and some amazing new opportunities. Nobody knows what I'm going to be asking people, just so you know, this is very impromptu today. This is being very off the cuff. So Ethan, can you talk to us a little bit about the EP services here and what capacity they now have for dealing with complex AFib in HCM? We'll start there, then we'll talk about sudden cardiac arrest issues.
Yeah, we're really fortunate in terms of also having an amazing EP team to work with. Specifically, Bruce Hook and Jonathan Silver, both really experienced electrophysiologists, both who throughout their career have really focused on complex AFib ablations. AFib, as many of you know, occurs in 20 to 25% of HCM patients. And it's much more challenging to manage than typical AFib. And that's in large part because in HCM, the top chamber of the heart, the atrium, which can drive atrial fibrillation, probably has its own myopathy set of problems. And so simple AFib ablations and antiarrhythmetics typically don't cure, quote unquote, atrial fibrillation and often need much more complex treatment. And Dr. Hook and Silver are really excellent in terms of their skills as AFib ablationists. And also something I didn't know initially, but there's what's called a hybrid AFib ablation procedure. And really lucky in terms of Lahey's skill of doing that procedure, which combines a surgical and percutaneous option. So a less invasive and a surgical option, which is a little more definitive as well in treatment of AFib.
There hasn't been a lot of data on that particular procedure in HCM yet. But what I've learned over the past couple of days, I think it's a great area for not only some clinical treatment, but also the opportunity to learn more about what its utility will be in HCM, not only here, but elsewhere. So just staying on the AFib thing for a minute, Prem, are you doing maze and atrial clips as well in your myectomies when called for?
Yeah, when patients with HCM have AFib, we do combine the surgical myectomy with a full maze and the removal of the left atrial appendage in order to prevent future stroke risk. So that is routinely done.
Excuse me, still getting over COVID here. Excuse the coughs. Marty, what else do we know about the EP department in terms of devices?
Well, I mean, we got with the EP department that Ethan was just talking about in terms of Bruce Hook and Jonathan Silver, who are the two lead EPs we're working with, enormous experience, say decades of experience with devices in patients with both HCM and non-HCM heart disease. And so we have enormous experience with both the implantation of primary and secondary prevention devices here, including, of course, the newer subcutaneous device as well, which is such an important option for many of our young patients who don't want to be subjected, of course, to the complications long-term of transvenous leak. So we've got a great experience with the sub-Q device here as well. So we're very excited to work closely with that group on all aspects of EP and HCM. And I'll also say, and I think we're going to get to this probably, one of the strengths, another one of the strengths that brought us here was the opportunity to work so closely with EP under the same roof, essentially. We'll talk a little bit about the center, the structure of the center, physical structure of the center in a minute, but they are working with us and are excited to work with us literally together in clinics seeing patients, so that patients, in other words, don't have to go to different area of the hospital to get their electrophysiology consultation or device interrogation. So it's all going to be literally under one roof. And so we're really excited about that aspect of the program as well.
So I'm going to talk a little bit about logistics. So I can see our car from here, and we're in the consult room of the center. So it's really convenient. We're right off of Route 95, and the parking is steps away from the door, which for those of you in heart failure, can be a little challenging managing a large campus. So, and it's free parking. I'd say it's free parking. You pay a pretty penny downtown Boston, but that's a whole other story. So we've got really convenient parking. We come into the building, up the elevator, a couple steps away, and you're at the HCM center. Marty and Ethan, why don't you kind of take us for a virtual walk in our heads through what this part of the clinic looks like. So who wants to take it?
Go ahead.
So
Ethan goes.
The clinic, I think, is really unique. So in that you have the ability for a lot of the non-invasive tests that we do to be done directly in the clinic. So both echocardiograms as well as stress echocardiograms are done in the clinic itself. We have we're going to have cardiopulmonary exercise tests, a CPET machine as well in the clinic space. Then we have 2 exam rooms, and then this consult room as well. And then as Marty was saying, The electrophysiologists here are also having kind of joint clinics with us. And we have all the device interrogation equipment here in clinic as well. So really can provide comprehensive care for patients on the outpatient setting.
And I'll add to that, if I have, Lisa, I think one of the observations that, we've had over many years is that one of the feedbacks that we've gotten consistently over now, again, 20 years was that it was really difficult for patients to come downtown and fight the traffic, a complicated parking lot. It's hard to get into these hospitals downtown. They're very difficult to navigate your way through. It takes a lot out of patients. It takes a lot out of anybody, but that takes a lot out of patients with heart disease. So that was always something that we heard a lot about. Patients wanted to come and see us, and then obviously appreciated that. But the act of coming to see us was really an issue. And so, part of the vision here is the idea that we can provide world-class care from medical to surgical for a disease like hypertrophic cardiomyopathy in an environment that provides a patient journey and experience that's much easier and more enjoyable, but easier physically and mentally on patients. And that's really, really important, particularly with a chronic genetic heart disease like HCM, where patients, of course, are coming not only yearly, but in some cases more than yearly to see their cardiologist for care. Okay. And I'll also emphasize that may in fact become even more important as we get into a newer era with therapies that look like they are going to have a role in this disease,
right,
the myosin inhibitors, but yet require a lot of longitudinal, meaning follow-up visits that are more than just the annual visit. Okay, so being able to provide easy access to world-class expertise, I think is only going to become more important in the future.
I couldn't agree more. I mean, with the REMS on the current Camzyos,
Right.
you're needing echoes every couple of weeks, and then every quarter. It gets a lot. It's a lot of visits. I really love the idea of this program specifically having the echo equipment embedded right here.
Right.
I can remember I've been around to a lot of cardiology programs over my life, and it's always this big walk to go to echo.
Yep.
And then if you're going to go do a stress test on top of it, so you're exhausted, you're stressed out, and you're moving all over the place to these different tests.
Yeah.
Now, the only test that's not here for obvious reasons is MRI, and that's in the other building, which is really not that far away. It is a nice light walk if somebody wanted to walk it. It's a little rainy today, and didn't want the hair to get wet, so we drove. But it's not far at all. It's literally 30-second drive, not even. So it's very, very convenient that way. Now, Prem, I was next door to your office today, which is in the other building that's 30 seconds away by car and probably 2 minutes by walking if you wanted to do it. And you're right by the EP department, but EP is coming over here. And will you come over here to consult with patients, or will they go to you?
We'll be flexible, and if required, we're happy to come here and see patients along with Marty and Ethan, or vice versa. If it from a time standpoint, if it turns out that there are 2 different points in time, happy to stagger it as well. So anything we can do to make the patient's journey better, I'm happy to do that.
So what's your thoughts? I think a lot of patients, in my experience, also kind of like seeing the hospital and where they're going to be staying after the myectomy as well. So I think actually my experience has been a lot so far of the 28 patients, they kind of like seeing you in your space and kind of knowing where they're going to be in terms of in the hospital.
And it's all really close. So everybody is right here. It's not a humongous campus, but it's quite sprawling. And there's lots of green space, which I really like, especially all the hospital stays that I've had. I've done inner city a lot. My transplant was in Newark. We're just going to leave it there, people. Not a lot of green space, not a lot of pretty space. But here you've got a lot of greenery, a lot of nice views.
And 2 hotels, by the way, that are very close, that are very nice, that have shuttles to the campus for patients. So for those coming from out of distance that need to stay overnight, either to see us or who may be having surgery or other procedures. Two very nice hotels.
Yeah, we're staying currently in the Marriott, which is literally down the street, like a half a mile. And it had a nice lounge, had a nice, common area, nice bar. But we weren't drinking. We were just kind of there having dinner. So it was nice. And you guys actually there was an event over there last night for, I guess, the fellows or something. You had some kind of a party over there. We didn't get to go there. We were out with you guys having dinner. By the way, there's somebody named Alex watching this right now. She might be related to you. I just saw her name pop up. So hi, Alex. And Laura says hi. Laura Prem. So that's a fun part about podcasting live.
The other part of it also is that the town of Burlington has right next to the hospital a large mall.
Ooh, I didn't know that.
And then,
You held that back.
And then plenty of food opportunities.
Yes.
So there's not only accommodation, there's nice restaurants and shopping and whatever else that might, excite patients. I don't know.
Well,
Yeah,
it's always
that's
fun
right.
to do that kind of stuff when
Yeah.
you're out doing something like a doctor's appointment. We used to always take our trips and do a little fun stuff while we were out there anyway. So that's good to know. And there's a really good cookie place. I'll get you guys the information on the cookie.
And I'll just also mention though that although we're a little bit outside the city, and we're talking about the advantages of that, of course, here, the other advantages too, or the other point to make about that is that for those that are flying in to see us, the distance from Logan to here is only 20-25 minute drive. So we're really not talking about having to necessarily drive that much longer than you would to any other hospitals, even in the city, because you just get on the highway and you're here 20-25 minutes from Logan. So, because a lot of our patients are flying in.
So if somebody were to be an East Coaster and taking the train up,
Yeah,
they could take it from
that's right.
all the way to South Station and
Yep.
then.
And then it's a 20-minute drive, depending on the traffic, to here. So it's not as if we're that far out that even that kind of transportation becomes that much different than it was before.
Yeah. Time-wise, it was the same for me to drive from Jersey to here as it was into, the center of Boston. But I didn't have to do that tunnel thing, which I was never really a fan of. Just to say, the whole dig thing, was not a fan of the dig. So that's good. So other services that you have here, I met your advanced heart failure physician yesterday. You want to talk a little bit about advanced heart failure services?
Sure. So very fortunate, Dave Vennessy, is Director of Advanced Heart Failure here. He has a lot of experience. We've known Dave. He used to rotate at the same hospital we were at. I think did he do his fellowship there as well a while ago?
Yep.
So known him for a long time. Excellent physician, really good guy. There's a lot of experience therefore as well, treating patients with HCM who develop advanced heart failure.
And then also just on top of that too, to expand on the issue of the very uncommon but important area of advanced heart failure with transplant. Lahey is part of a big healthcare network in Boston now called Beth Israel Lahey, and the other sister part of this network, Beth Israel, has just acquired the opportunity to advance forward with a transplant program. And so the opportunity to have heart transplant option within the system, so in other words, to still follow our patients until they get transplanted, is here as well. So that option for those that unfortunately need that.
Okay, so we've handled surgery, we've handled general HCM management, we've talked about EP, advanced heart failure. I did also meet your interventional cardiologist who will be doing your caths and the alcohol ablations that might be necessary. You want to talk about that service?
Yeah, sure. I mean, so the lead interventional cardiologist is Tom Piemonte, who I also have known for a long time. He's a senior interventional cardiologist. He has been practicing for decades in Boston, and he is widely regarded as one of the most well-respected, skilled, thoughtful interventional cardiologists in the city. And he has an incredible reputation. with great, and that comes with, of course, great outcomes. And that includes alcohol septal ablation, which he's been doing as a part of their structural heart disease interventional program for years now. And so Tom Piemonte is going to be leading that effort here in terms of helping to do those procedures and take care of those patients who need the less invasive option of alcohol ablation to relieve heart failure from obstructive HCM.
Want to say something?
Yeah, if I just along the lines of allied specialties, there's always a concern when patients come for myectomies about what is the surgical infrastructure around myectomies, right?
Please.
There's always a concern about anesthesia and other things. So just out of historical note, Lahey Hospital and Medical Center has actually been performing heart surgery for over 4 decades. So heart surgery has existed at Lahey Hospital for a very long time. And at this time, we have a group of anesthesiologists, cardiac trained anesthesiologists who are also trained in echocardiography, who are really world-class. Very good support system with our advanced practitioners, perfusion technologists.
I think they're about the most important people in the room next to you, of course.
Indeed.
Kind of keep your brain awake.
Yeah. And then, of course, we have a very beautiful state-of-the-art intensive care unit, and Dr. Zeimert is the chair of surgical critical care. So it's a well-oiled machine equipped to do high-end cardiac surgery, and they have been doing that for a while for those that may not be aware. And additionally, when I moved in July of 21 from the Brigham and Women's to Lahey Hospital, I brought with me my entire team. A very select group of core team members, including the chair of surgical critical care, a few advanced practitioners, and some anesthesiologists and nurses accompanied me over here. So we literally exported, a good team from the Brigham into an already existing good team at Lahey to make it a great team.
So what you're telling me is we took the best of one program and the best of another program, and we brought them together to build the Uber program.
Yep.
Is that what happened here?
That is exactly what happened.
Okay.
You couldn't have said it better.
And that was completely unplanned, by the way. So I do want to take a moment to just talk about the importance of the people behind the scenes that you don't get to see every day. And when I say perfusionists are like some of my, I admire them more than most people might think I would, because their technology and their specialty have really helped to improve outcomes from cardiac surgeries across the board. And that fear that people used to have about, I don't want to have open heart surgery, I'm going to end up with all these weird complications, and I'm not going to be oxygenated properly, and my brain isn't going to be my brain after surgery. It's the perfusionists who've made the improvements there. The surgeon skill is not to be discounted, but if you're not oxygenated, we don't really do well after surgery. So perfusion technology and having all of those, the techs and the PAs and everybody who knows how to do what they do in that OR, critically important. So much so that when I went in for my heart transplant, I don't know who knows the story or not, they would, do you want anything before you go in for surgery, Lisa? And I'm like, no. They're like, you don't want any, you don't want to go to sleep now? I'm like, nope, I want to stay awake. They're like, why? I'm like, I need to say hi to everybody. So I go into the OR and the perfusionists are in their corner and everybody's running around. I'm like, everybody stop. And they all just kind of looked at me like, what? I'm like, I just want to say thank you. I hope everybody had their coffee and I want you to have a great day, play good music, have good vibes, and thank you. And they all looked at each other and they're like, nobody's ever done that before. So if you're going to surgery, just say hi to everybody before you go to sleep. Makes you feel a little bit better. And I woke up and look at, that was 5.5 years ago and it worked. So it can work that way.
Well, I just want to say though that what Prem just said about, he's done an incredible job of bringing, as he said, together a group of people to make a great program even better over the last 1.5 years. That's translated, into what we have heard from patients, who've had surgery. Lisa, I mean, we've had patients comment already just how great the experience was of the post-op care.
Exactly.
which is obviously so
Yeah.
critical. We talked about what happens intraoperatively in the operating room, but also obviously the 5 or 6 days postoperative is obviously critical to it. The experience that patients have had because of the team behind Prem has been invaluable. In fact, as just one anecdote, I mean, one of these patients that we operated on came from Hawaii to get operated on here.
Really?
Yeah, from Hawaii. And she has commented multiple times in emails and other testimony just how happy she was with not only how good she feels right now from the operation, but the experience that she had in terms of post-op care was
That's awesome.
phenomenal. So Prem's done an incredible job to make that kind of experience what it is today.
So let's talk about travel-ins. So obviously those who are in, Massachusetts and the Boston area, it's easy to know where the program is and how to get here. I used to travel up here from New Jersey, 4 hours in the car, which became my watermark. I figured if I could drive 4 hours, 5 hours was acceptable. And that's what I thought a center of excellence should be 5 hours from everybody. We have hit that goal that most patients can actually have an HCMA recognized center of excellence within 3 hours of their home in most populated areas. So yay, we hit that goal, got a few more areas to hit. But what about travel-ins, fly-ins, and telemedicine? Can we talk a little bit about how people from a distance can get a consult and what that's going to look like now?
Well, I mean, I think, look, what we learned, obviously, one of the many things we learned during COVID was just how important and how effective telemedicine can be in general, but of course in this disease as well for patients who don't live close, and there may be other complicating factors for them to come in like COVID and et cetera, the opportunity to provide expert consultation through telemedicine was invaluable, and we will continue to have a place as we go forward. Good. Even though we're back to obviously in person, and that role is here too. We have the opportunity to do telemedicine with patients selectively to give that kind of consultation if they can't come in. I will also mention too that we happen to be very fortunate. Lahey has a very robust international program for patients. So international patients, there's a program here dedicated to helping them navigate coming, seeing the specialist, and getting the care they need from wherever they may be coming from. Okay. So we've got a whole team here that can help facilitate that as well.
And I think that's going to be really important going forward, not only here, but other places, telemed, travel in, specialty care. It's accessible.
Absolutely.
It's very accessible. We actually have a comment here from somebody on Facebook who was in the UK and was told by a cardiologist to go home and live their life, and no additional information was given, no treatment options were given, and they haven't been seen by a cardiologist since 2018. I highly encourage you to give us a call at the office, and we'll help maybe set you up with some other practitioners that we work with in the UK and maybe get that situation fixed up a bit. And Patricia's commenting that both her and her daughter have had myectomies, and now her granddaughter needs a myectomy, and they've had the treatment, they know how well it works, and they're really happy about the decision to have had a myectomy. So yay. So what else haven't we talked about? We've talked about interventional cardiology, electrophysiology. We've talked about surgery. We've talked about medical management. We've talked about new drugs coming up and the need for better echoes, and the convenience of the echoes here. So I've met yesterday with members of your mental health team, and we're going to start to figure out ways to integrate mental health services. No stigmas here, people. HCM is hard, and life is hard, and the world in 2022 is hard. And we want to make sure you have all of the resources needed. So we're developing that out. I met with dietitians and lifestyle to work on programs for that. They've only been here a month. It's going to take a little while to get all these other programs up and running. Research. Let's talk a little bit about research. What are we going to be working on? Clinical trials? What's happening? Ethan?
Well, both the clinical trials that are ongoing in HCM, excited to be a part of them, led by drug companies. So both, hopefully embryo study will get up and running soon. Cytokinetics, really excited about those. And then obviously also a bunch of investigator-driven research projects to continue our work in terms of Marty and Barry helping to define HCM, the treatment course for patients, and really Barry's work in changing the perception of HCM and a lot of the treatment options available for patients.
And then I'll just also mention, though, Ethan's being modest a little bit, but I mean, one of his,
Just a little.
just a little bit. Ethan's done an incredible job of pushing forward a number of clinical research initiatives that have made a huge difference in how we, look at and treat patients. But one of the things that Ethan's working on right now that's really interesting is the role of patient devices. So these patient, what do we call them? Wearable technology. Sorry, wearable technology. What the impact in terms of you get a lot of information from wearables, as you know.
Yep.
And patients are using them a lot now. And so the question really is, including detection of atrial fibrillation, which is an incredibly important arrhythmia in this disease. So Ethan's really starting to put together an investigation into what is going to be, or what could be the impact, the beneficial impact of wearable technology in a disease like this. So that's something to look forward to for the future.
I think it's going to be really interesting. I know a lot of people are capturing data, and when you know what you're capturing, and then we say very cavalierly, we'll just send it off to your team. Somebody's got to look at that. Somebody's got to manage it. Somebody's got to get back to you. So what are the best systems in place for that? What do we need to learn? How can we, the patients, be more effective in our communication with our team and not waste resources and time, but get the information that we need and they need and make it more meaningful.
And plus, these devices may give us the opportunity, because it's obviously patients have been with this disease their whole life. And so, talking about long periods of time. And so some of the information that a wearable device could give may help us to predict better or beforehand what patients may be headed toward in terms of issues to help them provide treatments earlier.
Yeah, the data captured on these devices is unbelievable. The question right now is, work to figure out what data is impactful and meaningful and predictive for patients to use it.
So additionally, we're going to be working on some projects together to help identify the undiagnosed, which is critically important to all of us. We don't want people out there with undiagnosed HCM and unmanaged or undermanaged. Like this woman who just posted here, I was diagnosed and told, go on and live your life. There might be things that can be done to improve your quality of life. And we have started talking about it in the past 3 years or so, but it's the burden of disease for HCM. We are living with the consequences every day. Our encounters with our healthcare providers are a couple times a year. So how do we make sure that we're living the best lives possible and not missing opportunities for surgeries and interventions and medications that can actually help us live more productively and thereby help our mental health and our financial health and our ability to work and be part of our families the way we want to be. So I think we're all focused on trying to make the most out of this one wild and precious life and be able to live it as best as possible. Prem, we have a question from somebody that was here this week. How many myectomies did you do before this year? And let's talk about what your numbers at this point and what we're looking forward to for the rest of the year.
Well, I think over a 15-year period at the Brigham and Women's, it is a center of excellence in itself, but the volume was not as high at the Brigham. So probably did about 150 in that period. And clearly in the last 5 months, we've done 28. And that speaks to the program that Marty, Barry, and Ethan have brought here. They are an international force in this area. So we've done 28 in the last 5 months. So if we were to just mathematically translate that, it would be about 75 a year, I would think. And I think Marty, you and Ethan, you would agree that that would be an appropriate.
Yeah, I think that's where you'll probably be this year. And I'm going to expect that, given the history I have with these guys and given the skills that you have and the team that I've seen, I think you're probably going to be a little bit higher than that next year. So take your vacations early. We want you to get some rest, but we also need you to be here. So take one weekend. Okay. Pediatrics. What's the plan with pediatrics? We're getting questions on.
Well, I think, so here's the answer to that. I mean, I think we have felt very comfortable as experts in this disease, taking care of patients who are in the adolescent age range with hypertrophic cardiomyopathy, even a little bit younger, even as adult, this is HCM is largely taken care of by adult cardiologists. And we have always felt and have, in fact, taken care of over the last 20 years of patients who are in the pediatric age range. And we intend to continue to do that here at Lahey. The institution supports that as well. There may be, with that said, there may be select patients in whom there may be the issue of complex procedures that need to be done. I'm talking largely about complex, maybe device implantations in really young patients, which is really a very complicated, can be a very complicated situation where we may be working with other colleagues who have expertise in that kind of area to do. But in general, in terms of seeing patients and providing consultation, we continue to do that.
So you can do family screenings here.
Correct. Family
And
screenings.
if you need advanced pediatric services, you have relationships with the individuals who are going to assist in that.
Family screening and evaluation, I think we can see patients basically age 8 to 10 and older.
And this is a good opportunity for me to remind everybody that on June 9th, I will be holding a Big Hearted Warrior tour with 5 pediatric cardiologists to focus in on issues related to the littles, like the little kids with syndrome disorders that are related to HCM, and then adolescents with HCM and others. So join us on June 9th for that program. So we have some other questions coming in. Now we have questionable people here, or questioning people, not questionable. You're not questionable people. I just don't have good English today. Genetics. What are we doing with genetics here? Is there going to be any research in the genetic space? Might have met somebody who told me a thing. So what's going on with that?
Yeah, I mean, we're offering, of course, we're offering clinical genetic testing for patients where that's applicable. Providing the opportunity to get that testing done. We provide the opportunity to interpret those test results in a clinically meaningful way, what the impact of those test results will be. And we also have opportunity for patients if they want to, or whether it's when it's the right situation to meet with genetic counselors here as well. So we have all of those services here to complement the genetic testing aspect to this disease. I'll also say, too, you asked about research, we right before coming on with you live, we were actually having a meeting talking about a project for which we are looking at right now, 1,000 consecutive patients that were genetically tested in our clinic, and the impact or relationship between the mutation and outcome. So that's an investigation that's going to be going on here, looking at the meaning of mutations as they pertain to natural outcomes for patients. So we are doing research in genetics as well.
Fantastic. So I have a question here. I'm going to give my opinion, then Marty can give his. Somebody says, does it matter where I get my cardiac MRI? Can I do it close to me, or should I go to a center of excellence? I'm going to say that the protocols that I've seen in some community hospitals may miss the mark and they may not get the right images. So I highly recommend all imaging be done at your center of excellence. Your community cardiologist has a huge role to play here in management and communication, and maybe, an event monitor and that type of thing is great to be done at home. But imaging, I truly believe, is best done at your center of excellence. Marty, Ethan, Prem, give me your opinions. You've heard mine.
I think under the ideal world, I completely agree, Lisa. I think if someone though has had a cardiac MRI in the community, it's hard to have insurance justify repeating it if it's recent. We obviously will then take a look at the MRI, make sure we have all the data from it that we really need to make sure we're caring for the patient appropriately. And then in the circumstance where it's not comprehensive study, we'll then repeat it if needed.
Prem, Marty, agree?
Great.
Agree.
I agree.
Okay, I'm going to take a moment to take a dive into MRI, into something that I recently came across. So during a navigation call, somebody was asking about, device decisions, and their local cardiologist did an MRI, and it came out at 28% scar burden. And that's quite high. And I said, why don't you have somebody else reread this? Because Spidey sense isn't working for me here. And if it were me, I'd want to know if it's really 28% or not. So we had somebody else read it, and they came back with 6%, not 26%, 6%. So 28 to 6%. Marty, could you please help me understand how there could be such a great variety in understanding what scar is and isn't on an MRI?
Well, yeah, I mean, I think without getting too complicated, the bottom line is that there can be aspects, and scar assessment is one of them, where expertise is really important here. The judgment and expertise of clinical experts is really, really important to be able to get the most reliable information that we can, because these are kind of complicated tests sometimes. They're specialty tests for specialty disease. And I think, for that reason, there's no question, and this has been your message all along, that is why care for hypertrophic cardiomyopathy really should, in large part, be these questions be evaluated at least once for patients at an HCM center of expertise. Because that's where the expertise will be concentrated. Of course, that doesn't mean we're obviously the HCM centers are working with the referring cardiologists. It's a team approach. But when we're talking about doing and interpreting a lot of the kind of testing for this disease, a lot of that's really most reliably done at centers of expertise, and scar assessment is one of those.
I'm going to put a last call for questions out to our Facebook watchers. And if you're listening to the podcast while you're hiking, walking, doing whatever, you can always come back and revisit us and go to our social media channels, and you can pick this up at a later date. If you're listening and you want to see who's talking to you, you can come to Facebook or YouTube and watch it there. So as I'm waiting for any other questions, any last thoughts or anything you guys want to share that I didn't bring up about the new program?
Say three things. Well, one is, it's an honor and privilege for us to have a program such as the one led by Barry, Marty, and Ethan to come and work with us at Lahey. I mean, like I said earlier, they're an internationally recognized force in this disease, and it's such a great honor for me and the institution that they chose to come work with us, and we're looking forward to a long journey ahead, providing great care to patients with this condition. Secondly, we're again honored and privileged to have you here, Lisa,
Thank you.
on behalf as the founder of the HCM Academy. And you're
Okay, I'm not the founder of HCM Academy, HCMA. But HCM Academy, that's a whole other program. We can talk about that later.
Okay, misspoke. Sorry.
That's okay. It's another A.
But the fact that you're here, and we greatly appreciate your stamp of approval of this program, and it goes a long way in making this program even better. So thank you for coming. Thank you for involving me in this podcast that you regularly do. And finally, from a very personal standpoint, I'd like to say that doing septal myectomy or extended septal myectomies or other versions of disease, surgical corrections for this condition is one of the most elegant operations in heart surgery. It is probably the most elegant operation in heart surgery. It is a very good anatomical and physiological exercise that has almost immediate and demonstrable effectiveness in the operating room itself. We can tell that this patient is going to do really well even before they wake up. And that is then justified as when they become better and they go on to lead their lives. So that is what keeps me doing this operation, and I love doing it. And I'm glad that I have bigger and greater opportunities to do this at Lahey Hospital now.
So I'm gonna pivot off of that and a comment that somebody else made here. I talked to you a little bit about this last night at dinner. I think when you have heart disease and you have a structural heart disease, if it's something else structural, we tend to fix it pretty darn quick. You meet a surgeon early on in a process if you have a valve problem, or if you have, a congenital defect, an atrial septal defect, a ventricular septal defect. We go in and we fix it and we normalize the heart to the best of our abilities. When you have HCM, some institutions in some countries say, when you're bad enough, we'll let you meet the surgeon. Don't be afraid of the surgeon. Okay, he's really not a bad guy, people. He does good things. Yes, I know it seems like a big deal to have open heart surgery. I've been there, I've had a transplant. I've also had abdominal surgery. And if I had to compare the two, abdominal surgery was way worse and more painful than the surgical part of my transplant. So I know it's scary. And if anybody goes into it saying, oh, yay, I want this, well, maybe you need to see the psychiatry department first. But it's not something you should be just stone cold against. It's doable. And look, I hardly have a scar. It's like nothing. So don't worry about the scars. Don't worry about that kind of thing. And don't be afraid to meet a surgeon. A, they're nice people, and B, they really can do a lot to help. So
They don't bite.
well, much. I don't know. Well, I don't think so. So no, I've never been bitten by a surgeon. So Barbara is asking Marty here for a little bit of an explanation that she's saying you gave an excellent explanation of NAVA versus surgery in the last visit. Can you share your thoughts on that with the audience?
Yeah, sure. Barbara's asking me to just comment about the newer medical therapy that's emerged recently called Myectomy, as it relates to what we've been talking about a lot today, the established kind of gold standard therapy for symptomatic obstructive HCM, surgical myectomy. And I think here's what I'll say. I think we're all enthusiastic about the fact that we have what looks like a very good additional medical option, therapeutic option to treat symptomatic obstructive HCM in addition to the other drugs that we have. So we're always open and excited about the opportunities for more options for patients. And I think the answer, I think Barbara maybe asked, what's the answer to, for mavacamten for surgery? And I think the bottom line is that to just make what I think is a fair statement at this point in time, that decision ultimately needs to be individualized, for each patient. So we have to really look at a number of different factors for any individual patient to determine what may be the best therapeutic option for them. Okay, so it's not a one size fits all situation, and it never has been for HCM. It's never going to be. So everything has to be individualized. Patients need to hear the pros and cons of all the options so they can be best informed about what the best choice for therapy for them is.
So I don't think we can ignore this question because there might be consequences later because it's from somebody named Alexandra. What are the benefits of myectomy versus alcohol septal ablation, Dr. Marin?
Thanks, Alex. Well, look, I mean, I think, again, as I was just talking about, in relation to mavacamten for surgery, I think a similar kind of principle applies to answering that question too. Alcohol septal ablation is a great procedure. It's very mature at this point. It's been around for 30 years. It's a less invasive, but still invasive catheter-based approach for relief of obstruction. And there may be reasons why a particular patient may be better suited for alcohol ablation versus surgery. I don't have time to get into all those. And so therefore, again, the point is that it's another option. The right choice depends on the individual patient, their anatomy, their desires, their comorbidities, a lot of other factors. And that's why HCM centers of excellence really are the place to have that conversation.
So that was a great wrap up, Alex. Thank you for putting that hook in there, because I think where we are today in June of 2022, we have a toolbox that has a lot of tools in it now.
That's right.
Figuring out which tool and when to deploy it for which patient and which anatomy, that, my dear friends, is where the artwork comes in. There's some clinical decision-making, and there's also a little bit of gut instinct from people who've been around and seen different anatomies. And yes, you want to lean into the clinicals and the statistics and all the published literature, but there is something about doing this in high volume and having seen 1,000, 2,000, 3,000 patients before that gives the program the ability to make and help you in that shared decision-making process, make really wise choices for your healthcare. You know, you got one heart. And my favorite line from my favorite poem is Mary Oliver, tell me what it is you plan to do with your one wild and precious life. And in that one wild and precious life, you typically only get one heart. So we want to keep them in there as much as possible. And we want to keep them working the best. So we want to make sure that we're deploying the right tools from the toolbox at the right time. I'm glad to say we have a lot of tools now.
Sure.
20 years ago, not so much so. But here we are today with a lot of great tools and a lot of great operators.
Yeah.
But you want to make sure you're going to high volume. You want to make sure you're getting the right surgery, the right intervention, the right drug. And the drug question is going to come up a lot. And there's a lot of logistics behind this. And I know there's still a lot of questions. And there's going to be more options available in the next 2 to 3 years. And they'll be more complicated to figure out which is going to be right for everybody. But if we all work together, and ladies and gentlemen, you're all going to be offered opportunities to be participating in a lot more research, not only with institutions, but through the HCMA and some work that we're doing. So the more we can learn about your experience, the more we can help the next person down the line. So stay with us on this. All right, so Prem gave final comments and then people asked a couple more questions. So Marty, Ethan, any final comments before we say goodbye to everybody today?
Well, from my end, Lisa, again, thank you for coming. I'm really privileged that Lahey has become an HCM Center of Excellence. And I really think it's going to be a great experience for our patients here.
I agree.
And I'll certainly echo those comments from Ethan and just say thank you. We've been friends and have worked together for over 20 years now.
I'm not that old.
Yeah. So it's been actually that long. And you're part of the family in a lot of ways. And I really appreciate, and the patients all appreciate all the efforts that you and the organization have done to advance the knowledge and understanding and access to information for this disease. There's just no question that that has been a paradigm changer for this disease and has set the example and bar for other diseases to follow. So we appreciate you coming for that reason and giving us the opportunity to talk about our program in this way. And as Ethan said, we are thrilled to have the opportunity as a 2.0 to do what we've been doing for a long time, but to do it better by partnering with people like Prem, who we couldn't be more thrilled to work closely with, as well as all the other team members we talked about here at Lahey, to really advance clinical care for this disease in a way that we're excited to do.
Fantastic. And our favorite hockey player from Long Island says hi,
Okay.
and he'll see you next month.
Okay.
Hi, Seth.
Tell them the parking's free. Yeah.
Parking's free again. It's kind of a big deal when you've
It
been in
is.
the
That's
city a
right.
long time.
That's
And
why I said it again.
it's like $40 to go
That's
to
right.
park in some places. And you don't have to worry about that now. So we're going to say thank you very much to everybody and whoever's calling me. I'm going to hang up my wrist phone. Don't you feel like get smart when your phone rings on your wrist these days? Or am I feeling old? Thank you all for joining us. Again, just a couple of programming notes. Number one, next week, next Thursday, I will be actually doing two things next Thursday. I will be speaking in Washington, D.C. at a policy summit and talking to lawmakers and individuals, policy wonks, about some of the policy issues that are facing the HCM community, reimbursement, access to care, and things on that nature, quality generic drugs. Stay tuned. I may have an interesting announcement in about 3 weeks on that. I'll just tease it at that. What next Thursday night is the Pediatric and Adolescent Big Hearted Warrior Tour. And then the next week, I get to see one of my other favorite people on the planet, and that is Dr. Bill Roberts down in Texas, where we will be doing live anatomy with HCM hearts from donor transplant recipients. And I will be joined by one of those transplant recipients in person and another one online as we section their HCM hearts and teach the world what an HCM heart really looks like. That will be on the 15th. Because of some internet issues, we're not sure if it's going to be live at about 11 a.m. or if it's going to be pre-recorded, and then we will live take your questions live when we air the pre-recording. But we'll let you know about that as we get a little bit closer and we see if the internet is going to work for us or not in a basement at Baylor. So join us there. You can get the information on the website for the registration. All of our programming will be live streamed on Facebook, and then it will be captured for other purposes on YouTube and the website. Thank you all for joining me today. It's been great being here, and we're going to be getting back in the car soon and heading back to Jersey. But we are really happy that we got an opportunity to come visit you guys here up in Boston in your new home in Burlington. So thank you all, and thanks to the rest of the Lahey team, who was very wonderful to meet with over the last 2 days. And we look forward to lots of great things.
Thank you.
Bye, everybody. And